Well, good afternoon. I first want to thank Dr. Moyad, Dr. Scholes again for giving me the opportunity to talk about really sex and testosterone. It's a great topic after lunch, and I hope you'll enjoy it. There's 5 main areas that I want to accomplish within the next 45 minutes or so. Dr. Moyad asked me to give a talk about male and female sexual dysfunction, testosterone replacement therapy for men and women, and I'm going to also talk about penile rehabilitation as well as my 5th topic. So these are the 5 topics. I want to teach you and explain to you what are the current treatment options for erectile dysfunction. What do we have available today? I want to show you new paradigms, different ways of thinking about erectile dysfunction, and the new treatment options that are coming in the future. We will talk about female sexual dysfunction. How do you diagnose and treat women with female sexual dysfunction? And then this concept of erectile preservation following prostate cancer, whether you had a radical prostatectomy or radiation. And finally, testosterone therapy for men and women. So let's get started. So this is one of the older studies. It's the Massachusetts Male Aging Study, which showed that roughly 52% of men between the ages of 40 and 70 had some degree of erectile dysfunction, whether it be mild, moderate, or severe. And when patients come into my office and they say, "Doc, I can't believe this is happening to me, and why is ED happening to me?" I explain to them that erectile dysfunction is a natural part of aging. Every single man is going to get erectile dysfunction. I'm sorry to break it to you today. Every man's going to get erectile dysfunction as long as you live. In fact, if you look at the statistics, 40% of men at 40, 50% at 50, 60 at 60. If you live to 100, you will get erectile dysfunction. It is a natural part of aging, right? So what can we do? We can do things. If, for example, if you are scheduled to get ED at 65, we can shift the curve. We can shift it to 75. There are things we can do to rehabilitate and exercise the penile tissue. But again, it is a natural part of aging. So there are many causes of erectile dysfunction. When I was in medical school, they taught me the mnemonic VENT, V-E-N-T. VENT, V meaning vascular, E meaning endocrine, whether it be hormones and testosterone, and N meaning neurologic trauma, T meaning trauma as well, and there could be drugs as well. On the urology boards every year, the drug that we always talk about is the beta blocker. You put someone on a beta blocker, they're notorious for causing erectile dysfunction. And many of you can imagine how many patients are on beta blockers in the United States. And then there's psychogenic causes as well. So again, these are the common etiologies for erectile dysfunction. So we know that many men with erectile dysfunction are actually not being treated. In fact, up to 75% of patients with ED are not being treated. Some other studies found up to 77% of men are not being treated. Why are these men not being treated? Many of them are ashamed that they have erectile dysfunction, and many of them are concerned that their physicians won't take their problem seriously. And I think that's a very important point. So my wife is a family practitioner, and I tell her, I said, "Do you screen for ED?" And she said, "It is very difficult. I have about 13 to 14 minutes per patient. I have to get through hypertension, hyperlipidemia, CHF, every other disease, and ED tends to be at the bottom of the list for most primary care physicians. They don't really screen for it." So I think it's important. Many times I tell patients it may be up to the patient to initiate the conversation on ED because many physicians are probably not going to bring it up. So these are the current treatment options that we have available, and I divided it into first-line, second-line, and third-line therapy. And the reason I do that is because first-line therapy is really predominantly 75% of the market. And you remember these are oral medications: Viagra, Levitra, Cialis, Anaphylm. We'll talk about those. If the first-line therapy is not effective, we go to second-line therapy. These are urethral suppositories. These are suppositories placed into the penis. There are injections, and then there's a vacuum erection device. And then finally, there's third-line therapy, which is a penile implant or corrective vascular surgery, which I very rarely do, about 1% of the time. So this is kind of the algorithm that shows you what we have available to us today. And I do want to spend a few minutes talking about these treatment options. So remember, there are 4 therapies for oral. It's sildenafil, tadalafil, and vardenafil, also known as Viagra, Cialis, and Levitra. Remember that the half-life of Cialis is longer. It's typically 17.5 hours. So if a patient takes Cialis, typically they take it at Friday at 5 o'clock. It usually lasts for 36 hours. They're covered for Friday night, Saturday morning, Saturday night, Sunday morning. It lasts a long time, right? So typically one pill can last a long period of time. Viagra typically will last about 8 hours, and same with Levitra. Now remember that these medications really work best when taken on an empty stomach. What is the biggest mistake most patients do? They go out, they have a wonderful meal, they drink a bunch of wine, they come home and they want to have sex. That is the worst time to take Viagra, right? That is the worst time to take Viagra, but that's when they take it. The best time to take Viagra is at 5 o'clock before you go and have dinner, then go out and have your dinner, have your wine, come home. It's going to be far more effective if you did it that way than if you took the Viagra after dinner. Right? It's not going to wear off. It'll be in the system till 2 in the morning, so don't worry. But take the medication on an empty stomach. It's far more effective. Same with Levitra as well. So again, one of the most common medications also with Cialis is that there's a daily dosing. And I'm a big fan of daily dosing. I think daily dosing is probably one of the only true cures for ED. Every day it puts blood and oxygen into the penile tissue, whether the patient's having sex or not. It's extremely effective. And many of my patients will take daily Cialis with an on-demand PDE5 inhibitor on top of that. What do I mean? They'll take daily Cialis every day, and when they engage in sexual activity, off-label, they'll take 100 milligrams of Viagra or 20 milligrams of Cialis. It tends to be very, very effective. So this is the newest drug on the market. You may have heard of it. It's called Stendra or Avanafil. The FDA has now given this a 15-minute onset, so it's the fastest onset in the market, and it can be taken with food and alcohol. It also has very minimal side effects because it is very specific for the penis as opposed to other organs. So a lot of times patients won't complain of the headache or the stuffy nose or the back pain with Avanafil. So in my experience, it's been good. It doesn't work in all patients. I've found that those that it does work, it works very well. Those that it doesn't, it just doesn't work. But again, 15-minute onset and minimal side effects. So there is some concept about testosterone and Viagra-like drugs. And I want to point out that we know that Viagra-like drugs, Viagra, Levitra, Cialis, they tend to work better in men who have normal testosterone levels. They tend to not work as well in men who have low testosterone levels. There are several studies, the third one was one that we published as well, demonstrating that those men who have low testosterone levels, when you give them the Viagra and it doesn't work, if you give them back testosterone and then try the Viagra again, up to 50% of those patients that were non-responders will become responders to Viagra-like drugs. So again, when patients come in and say, "Doc, my Viagra stopped working," the first thing we like to do is check their testosterone level to make sure it hasn't gone low. And if it's low, we replace it and try to see if we can salvage those non-responders to Viagra-like medications. So this is intracavernosal injection therapy. You may be familiar with it. There are two types. There is the one you can get commercially at Walgreens and CVS, also known as Edex or Caverject, and that's pure prostaglandin, alprostadil. 90% of urologists will actually give you something called Trimix, which is compounded from a compounding pharmacy and has 3 medications in there. It has not only the prostaglandin, but it also has phentolamine and papaverin. And we put this in a combination formulation. What's nice about it is I can adjust how much I put in there. And I can adjust not only the strength of the solution, but I can adjust how much I can give you. And if the solution no longer becomes effective, all I do is give you the next higher dose or strength of the solution. So quite honestly, it's very easy to titrate. It's very easy to use. We always like to do the tester in the office because if you do take too much, you can develop a priapism, which is a prolonged erection where we have to meet you in the ER and physically bring it down with the medications or possibly surgically. So we have to be very careful in teaching you how to use it. But it's extremely effective. It's extremely effective. We tell the patients to inject at the 2 and 10 o'clock position. You alternate sides because you don't want to develop scar tissue. You can only inject 3 times a week in our practice. But again, it's extremely effective. And what's nice about the Trimix, it's very affordable. While the Edex could be up to $60 an injection, the Trimix is anywhere from $3 to $5 an injection, and it's far more effective than even the oral medications. Some patients say that, I'm concerned about the Trimix because it has to actually be refrigerated, right? And that's an issue. So many patients say, when I go on trips, I don't want to refrigerate the trimix. And there's now compounded versions of lyophilized trimix that does not need to be refrigerated. So basically, it comes with these small vials. It comes with a 10 cc. It comes with a normal saline vial as well. You drop the normal saline. You inject how much you need into one of these small vials. Then you use that medication. So you no longer need to freeze or refrigerate your medication with trimix. So this is Muse, which is a urethral suppository, and it's exactly what it is. It's a button on top. There's a medication that comes from the bottom. This is just a depiction of a man placing the urethral suppository into the urethra, and it dissolves. This is, I would say, moderately effective. These are used in patients who, A, don't want to use an injection, and that's fair enough. And secondly, it's very effective for men in combination therapy. Let me give you an example. Let's say a patient says, look, I'm using Viagra and I'm getting about a 70% rigid erection, but I can't penetrate. But I don't want to use an injection. Is there anything else you can do for me? I say, well, use the Muse in combination with the Viagra. And in those patients, it's very effective. So combination Viagra Muse or combination Cialis Muse gives the man the extra rigidity that he needs in order to be able to penetrate. So these can be expensive, and I know they're expensive, but they can also be compounded as well. My compounding pharmacist can make Trimix gel, which is about $7. This Muse is about $60. So again, we tend to compound the Muse and get a Trimix gel instead of giving Muse. This is a vacuum erection device. It's available. It's been around for decades. It's exactly what it sounds like. It's a vacuum, right? So the vacuum is placed on the penis. It provides suction. It makes the penis rigid. And then a band is placed at the base of the penis. It is quite effective. One of the main benefits is cost, right? Because everything that I'm showing you today, it costs every time you have sex, right? Viagra, Levitra, you pay money every time. But with the vacuum erection device, it's a one-time cost, and then you don't pay every time you use it. So there is a benefit. So many patients will use the vacuum erection device in combination also with Levitra or Cialis. They'll also use the vacuum, and then they'll inject the needle as well. But it is effective, and it is very cost-effective as well. I think one of the greatest advents in this field is the penile implant, and I don't mean to brag, but this was invented at my institution in 1972 by Dr. Brantley Scott, and it's used throughout the world. And typically, it's about an hour procedure where we implant a pump in the scrotum. It's not touching the testicles. It's in a separate compartment called the Dartos pouch. We have 2 cylinders that are placed into the penis, and then we have 1 reservoir that goes behind the pubic bone. And it's pretty simple. All it is just normal saline. All it does when you squeeze the pump, it pulls water out of the reservoir and places it into the cylinders. And the penis is rigid. When the patient finishes engaging sexual activity, he releases the pump, the water comes out of the cylinders and goes back into the reservoir. So if you think about it, theoretically, any man who's willing to get a penile prosthesis, we could theoretically cure their ED, right? Theoretically, you could cure every man's ED if they're willing to have or able to have a penile prosthesis. If you look at satisfaction scores, and this has been done, satisfaction scores in men who get injections and they get vacuum and they get Viagra-like medications, the penile prosthesis always has the highest satisfaction scores over any kind of medication we can give a patient. It's just the phobia of saying, I have a prosthesis. So many men are very nervous. But again, the satisfaction for patient and partner are the highest with a penile prosthesis. So I'm going to completely change the way you think about ED today, because I think the way we treat and diagnose ED is quite barbaric, to be honest with you. ED is a disease. You should think of ED like any other disease, like cardiovascular disease, any other disease. And I'll give you an example. If you broke your leg today, I would have 2 options. I could give you Vicodin for the rest of your life, and you could walk, and you could still take the Vicodin and continue to walk, or I can truly fix your leg, right? The problem with Viagra, it's just like Vicodin. The disease is getting worse every single day, and all we're doing is trying to mask it with a pill until the Viagra stops working, right? We're not treating the disease, we're just covering the disease as it's getting worse every day. So I want to show you a different way of treating the disease, treating erectile dysfunction, and actually reversing the disease process as opposed to just putting a Band-Aid on the problem. So we're going to talk about a fancy word called the endothelium, but before I get to that, I'm going to talk to you about the correlation between erectile dysfunction and cardiovascular disease. So a very clever physician named Ian Thompson in 2005 ran the prostate cancer prevention trial, and he had a placebo arm of roughly 4,200 men, and he followed these men. None of these men had erectile dysfunction. But when they developed erectile dysfunction, from the day they developed erectile dysfunction, 15% of them had a heart attack or stroke within 7 years. 15% had a heart attack or stroke within 7 years. Suggests that maybe ED was the first sign of their heart attack or stroke. Others have shown the same. Montorsi showed that the prevalence of ED was 49% in men with symptomatic coronary artery disease, and these men typically had ED about 3 years before they had their heart attack or stroke. So how do you explain this? Why would a guy have ED before he has a heart attack or stroke? It doesn't make sense. Well, it is clearly explained by what we call the arterial diameter theory, and this is what it states. The smallest arteries in the body are the penile arteries, they're only 1 to 2 millimeters. The next size are the coronary arteries, they're 3 to 4 millimeters. The next size are the carotids, which are typically 5 to 7 millimeters. And finally, the peripheral arteries typically tend to be about 8 millimeters. So remember, if you're going to occlude an artery in the body first, you're more likely to occlude the penile arteries before you occlude the coronary before you occlude the carotid before you occlude the peripheral. And if you look at statistics, men were more likely to get ED before they get a heart attack. They're more likely to get a heart attack before they get a stroke. And they're more likely to get a stroke before they get peripheral vascular disease. So it is true. If a man getting ED today, if he has risk factors, say he's obese, he's diabetic, and he has ED, we send them for a cardiac stress test because our ability to find men is about 37% of them have occult cardiovascular disease. They don't know it, right? But ED could be the first sign of a heart attack or a stroke. So we believe that the common link is this word called the endothelium. It's just a fancy word. Let me tell you what it is. It's the lining of the blood vessels. So everyone has blood vessels. We have a lining of the blood vessels called the endothelium. And the endothelium, think about it as the computer, the brains of that blood vessel, right? It knows what's bad in the blood vessel, it knows what's good in the blood, and it teaches the blood vessel to contract or to relax. So it's basically the brains of the blood vessel. Well, if the brains of the blood vessel get damaged, what happens is that blood vessel gets stiff. When it gets stiff, it gets a plaque. And when it gets a plaque is when we start getting the heart attack and the stroke and the ED. So we want to keep that lining of the blood vessels, the endothelium, healthy. If we keep it healthy, things get to be very good. If we keep it injured, we start getting diseases. Right. So how can we assess the endothelium? Well, there's a lot of ways to assess the endothelium. There's markers in the blood to know how healthy your endothelium is. There's imaging. And there's also new technology out there called peripheral arterial tonometry. And this is what we do at Baylor on all the patients that come in for ED. This is an FDA-approved device, and basically the patient will come in, and we put this device, it's a blood pressure cuff on their arm with a probe on the finger, and there's a probe on the contralateral finger. And I raise that blood pressure cuff to very high levels, and then I release the blood pressure cuff. If a patient has very healthy blood vessels, the blood vessels in the finger dilate very nicely. If they have very diseased blood vessels, the blood vessels in the finger don't dilate very well at all. So in the Mayo Clinic in 2004, they did something very clever. They did this on over 300 patients, then immediately they took those patients into the cardiac cath lab, and what they found was if your finger doesn't dilate very well, you're more likely to have a blockage in your heart, right? So it's a systemic disease, right? So if the finger is a surrogate marker for how well there could be an occlusion in the heart. So at Baylor, we said we're going to copy the same study. We're going to do this on 200 patients, but we're going to do a penile ultrasound on all these patients as well. And we found the exact same thing. If your finger doesn't dilate very well, if you have poor endothelial function, you are more likely to have poor blood flow in the penile arteries as well. A very strong correlate as well. So again, the endothelium is the common link. So I think some of the smartest doctors are actually not urologists, they're actually cardiologists. They are unbelievably bright because they figured out this endothelial business probably a decade before we did. And many of you have heard of the Dean Ornish study and eating healthy, and they can show that they can reverse cardiovascular disease. Well, the cardiologists showed that if you improve the endothelial function, they showed that you can actually improve cardiac blood flow. They showed that you can actually treat, if not reverse, coronary artery disease. Pretty amazing in the heart and the carotid as well. How do the cardiologists do it? They tell you to have diet and exercise. They put everyone on a statin. They improve their insulin resistance with metformin, other medications. They put you on an aspirin. They tell you to stop smoking. Some of them are even using chronic PDE5 inhibitors. And believe it or not, some are even using testosterone therapy to improve the endothelium, improve cardiac blood flow, and improve coronary artery disease. So this is pretty simple. It's not rocket science. If you believe that the endothelium is the common link between erectile dysfunction and coronary artery disease, and the cardiologist already figured it out, all we have to do is just copy this paradigm and just use it to treat erectile dysfunction, right? It makes sense. Copy the exact same paradigm. And so you may say, well, look, Khera, how can you tell me that these diet and exercise statin can improve ED? There is excellent data to support that these will absolutely reverse the ED process. I'll give you some examples. Esposito in 2004 had a beautiful study in JAMA, randomized single-blinded trial of 110 men, and they had to all have erectile dysfunction. 55 of them were allowed to do a diet and exercise program, and 55 were not allowed to have any exercise or intervention whatsoever. And what they found was that if you were on a diet and exercise program, after 2 years, you'd lose weight. That makes sense, right? You're going to lose weight. But they also found that those men that lost weight had a significant improvement in markers in endothelial function, which we talked about. They also found that if you lost weight, just weight loss, significant improvement in erectile function scores. No other intervention at all. No Viagra, no Levitra, just losing weight. And if you look at the multivariate analysis, the markers of endothelial function like C-reactive protein were independently associated with changes in erectile function scores. So again, a pretty impressive study. We really push hard in diet and exercise with patients who present with erectile dysfunction. Just a comment on statins. I'm not going to show you all the studies, but I will show you one. This was just a review article. It was a meta-analysis of 11 randomized trials assessing the effects of statins on erectile function. And they showed that the IIF scores, or the erectile function scores, increased by 3.4% points, which is considered significant over placebo. And what I thought was interesting is that the increase in IIF scores, or sexual function scores, with statins was approximately 1/3 to 1/2 as seen with a PDE5 inhibitor. Pretty impressive. So these statins are 1/3 to 1/2 as effective as when you give someone Viagra, and age was not a variable at all. Chronic PDE5 inhibitors. So this is really one of my favorite therapies, as I mentioned earlier, because chronic PDE5 inhibitors every day are putting blood and oxygen to the penile tissue. I want you to think of the penis as just two muscles running in parallel, because that's all it is. It's just two muscles running in parallel. And if you, as you know, if you don't use a muscle, for example, if I put your arm in a cast today and took that cast off in 6 months, that arm would look terrible. It'd be atrophied, it'd be withered, right? The penis is identical. If it's not being used regularly, it will atrophy. And if it atrophies, it's harder to use it because you develop something called venous leak. One of the only things that's been shown to improve blood flow into the penile tissue and improve the muscle within the penis is daily PDE5 inhibitors. Every day putting blood and oxygen to the penile tissue. Very, very effective. Just a study by Aversa where he gave men on-demand Cialis versus daily or chronic Cialis, measuring blood flow in the penile tissue, measuring endothelial markers. What did he find? If you had daily or chronic PDE5 inhibitors, not only did you see a significant improvement in endothelial function, but even when he stopped the study and you measured the endothelial function in those men that took chronic PDE5 inhibitors versus those that did not, the effect was still persistent 3 months later, right? Suggesting a profound effect with daily PDE5 inhibitors. So, and then finally, testosterone therapy has been, there's some controversy with cardiovascular issues, but I just want to point out one other study by Aversa where he was looking at changes in the carotid. So he's looking at the plaque in the carotid. He gave half these men testosterone, he gave half these men placebo, and he's looking at improvements in endothelial function. He had to stop the study early, and the reason being is because those patients that were getting testosterone were seeing a significant reduction in the carotid plaque. Right? And he stopped the study early because the plaque was reducing in those men that were on testosterone, and they felt it was unethical to continue the study in those men that were getting placebo. So this is our protocol in terms of patients who walk in with ED. We do check markers for endothelial function. We do testing in terms of endopat, penile duplex biothesiometry. But if a patient has a low score on the endopat and they have less than 1.8, we definitely want to do lifestyle modification. We also, if they have 2 cardiac risk factors, I send them to my cardiologist to get a stress test to see if they have occult cardiovascular disease. And if they have low testosterone, we do treat the low T. So I'm going to switch gears here a little bit, because when I started treating men about 9 years ago, these guys would come in and I would get them to have these great erections finally after so many years, these amazing libidos. But the problem was they would go home and they had no one to have sex with. Right? Because their wives had not had sex with them for 10 years. Many of these women got very upset. They said, look, things were great till he met you. We weren't fighting. Now he's chasing him around the house all the time. And it's a big problem. Right? And I've quickly learned that it does not make any sense to raise the libido and the sexual function of one person and leave the other one low. Either leave them both low or both high. But when you have one high and one low, it's a big problem. It's a big problem, right? So again, you really want to see, if you're treating men, helping them get these great erections, great libido, you better think twice on what are you really accomplishing if they have no one to have sex with, right? So that's why we treat women for female sexual dysfunction. Female sexual dysfunction, male sexual dysfunction is a couple's disease. It makes no sense to focus on one partner. You focus on the couple. We ask them to come in together as a couple. And when you improve the sexual function of one partner, believe it or not, you're actually improving the sexual function of the other. They're very synergistic. They pull each other on scores, and I'll show you what I mean by that. So if you look at the prevalence of female sexual dysfunction, and these are women, you have these men come in and you give their wives questionnaires, roughly 43% of women have some degree of female sexual dysfunction. And these statistics are pretty consistent with the national statistics as well. But unfortunately, most women, 91% of them, do not seek treatment. They just live with it. 91% of women just live with female sexual dysfunction. Only 9% seek treatment, and the most common forms of treatment are lubrication or hormone therapy. So there was a very clever study by Erwin Goldstein. It was a randomized, double-blinded, placebo-controlled trial, and I thought it was very clever. What he did was this. He gave these guys Levitra, and he gave half of them placebo. And he said, look, I don't want to meet your wives, but I just want you to give your wives a female sexual function index. It's the most validated questionnaire for women's sexual function. And he gave all the wives a female sexual function index, didn't want to meet them, didn't want to talk to them, but he gave the men half placebo, half of them Levitra. And he found something very interesting. In those men that got Levitra, who also saw a significant improvement in their erectile function scores, their wives at home saw significant improvements in female sexual function index scores, whether it be overall satisfaction, arousal, libido. Those men that got placebo, their wives saw no change, minimal change in their female sexual function scores. What does that suggest? It's intricately tied together, right? You improve the sexual function of one partner, you're actually improving the sexual function of the other. At Baylor, we did very similar studies where we gave women testosterone, didn't want to meet the men, and erectile function scores significantly went up. What am I saying? One of the best ways to improve a man's erections is to skyrocket his wife's libido. Absolutely makes a significant impact on the quality of the erection. So when we treat men for erectile dysfunction, we'll give them testosterone, we'll give them penile injections, maybe a penile prosthesis, maybe Viagra, but your take-home message today is you have to focus on the female partner, which is generally missed in most evaluations. So men and women are very different, and I'll be honest with you. So we treat a lot of women, we treat a lot of men. I give men Viagra, I give them a little testosterone, and it's like an on-off. Women are much more complicated, and I'll tell you, there's a lot of issues that we have to go through in our practice. So when we treat with women, we have a program, and we have a sex therapist on hand who sees the patients. We have patients, some women need lubrication, weight loss, pelvic floor exercises. Some of them have vaginismus. They have a lot of relaxation issues. And we want to be careful with antidepressants. Antidepressants are notorious for killing a woman's libido and sex drive. And then also we want to treat the male partner as well. There are many ways that we treat female sexual dysfunction. There's a hormonal and non-hormonal approach at Baylor. Typically in hormones, I look at estrogen, progesterone, and testosterone. I tell the women it's the triangle, estrogen, progesterone, and testosterone. In 2003, there was some concern from the Women's Health Initiative that estrogen and progesterone may be linked to cardiovascular events and cancer. And that is true. There is a mild effect, and I would argue it's extremely mild. We've been using testosterone in women since 1939, and there's been no indication of cancer as of yet. But again, we do think it's important to have that discussion because all three, estrogen, progesterone, and testosterone, can significantly improve a woman's sexual function. There's a non-hormonal way to do it as well. We can use Viagra in women, but remember, Viagra only increases her arousal. It's lubrication to the vagina, blood flow to the breast. It does not increase her desire for sex. It's only arousal. We can use Wellbutrin, which increases her desire for sex because it increases dopamine. I don't know if many of you know what Doscinex and Mirapex is. Those are used for restless leg syndrome. And if you remember what the announcer says on the TV, he says, if you have increased gambling urges or sexual desires, please notify your doctor immediately. Because one of the side effects is increasing dopamine. And so we use these medications to increase the dopamine level to help with sexual function. We use natural supplements like arginine, carnitine, and citrulline. And more recently, we are now using AD. And I don't know if you're familiar with AD, but in 2015, of October 2015, last year, the first drug ever to treat women for female sexual dysfunction came out. First drug ever. It's called AD. Some people call it the female Viagra. And really, it's really not a female Viagra. It's a drug that was developed by Boehringer Ingelheim to be an antidepressant. And when they were studying the drug, instead of being an antidepressant, all the women wanted to have sex. And that's how they found the drug. And then, so basically, they brought it to the United States, and now it was approved. Until this was approved, we had 26 drugs for men for sex. We had 0 for women. And now we have the first drug, which is called AD for women. And so a woman takes it every day, like she would take it, and what it does over time will increase her desire for sexual intercourse. On average, it was 2.2 to up to 5.3 times per month in the studies. So future treatments for erectile dysfunction, we are doing a ton with stem cells, and many of you have heard of stem cells. Stem cells are cells that can turn into any part of the body, and you can get the stem cells either from adipose fat, and we usually get it from the abdomen, or you can also get it from the bone marrow. There are only 7 studies in the United States treating men with stem cells for erectile dysfunction. We are one of the sites at Baylor. 3 of those studies are for radical prostatectomy, post-radical prostatectomy. The other 4 are for treatment of ED. And there is definitely some merit in the use of stem cells in the future. As I mentioned earlier, when the penile tissue, the muscle, atrophies, it's hard to keep the blood into the penile tissue. But when we put these stem cells into the penile tissue, not only do we see increase in blood flow, but we see hypertrophy or growth of the smooth muscle, and we prevent venous leak. So there's some merit to this. You'll see more and more in the future. What's another interesting therapy is shock wave, shocking the penis, believe it or not. This came from the machines that make shock waves for stones, if you've heard of shock waves for stones. Well, now we can use a machine, a device that delivers 1,500 shocks to the penis 2 times a week, and is typically given every 3 to 6 weeks. And we are involved in one of the studies, phase 3 studies here in the U.S., and the concept is pretty simple. What it does is when you shock the penis, you actually induce neoangiogenesis, more blood supply into the penile tissue. And so you increase the blood flow, and this theoretically could be used in the future for post-radical prostatectomy, ED as well. So I want to change topics a little bit about erectile preservation, because many of you in the room are very familiar with prostate cancer and some of the sequelae. And I really want to talk about this concept of erectile preservation after prostate cancer. So everyone uses this word penile rehabilitation. I do not like the word penile rehabilitation. It does not make any sense at all. Rehabilitation means the process of restoration after illness or injury to regain maximum function. Let me tell you something. The day a man has a radical prostatectomy, if you did a biopsy of his penile tissue the day after his radical prostatectomy, that tissue is extremely healthy. It looks great. There's nothing wrong with that tissue the day after surgery. It is over time that that tissue becomes worse and unhealthy. But the day after, it is very, very healthy. So what we're really trying to say is erection preservation. We're trying to preserve the tissue. We're trying to prevent it from becoming bad, not trying to rehabilitate it, right? So how do we prevent the tissue from becoming injured? So as many of you know, when I talk to patients about prostate cancer, I tell them there are only 3 things you got to worry about. You got to make sure that the cancer comes out. And I'll tell you, the surgeons now are excellent at making the cancer come out. You got to make sure that you're not in diapers after the surgery. That's true. And finally, you got to make sure that you have good erections after surgery. Those are the 3 main things we worry about. With the advent of the robot, the skills of the surgeons these days, many patients are getting the cancer out, and the incontinence rates have dropped down significantly. But the erectile dysfunction rates are all over the board. They're literally all over the board. And I think in the future, most patients are going to be paying a lot of attention to erectile function rates that surgeon can provide after the procedure. So do urologists implement penile preservation programs? They absolutely do. This is an international study, 41 countries. Roughly 84% of physicians offered some type of erection preservation. The most common is Viagra-like drugs. They give their patients Viagra or Cialis. Some will give them injection therapy. Some will use vacuums. And very rarely will they use Muse. Now, the reason why a lot of these are not being initiated, 50% of the time it's because the physician says it costs too much money, which is true. They're very expensive. And 25% of the time they say, show me the evidence. Where's the data to support this? Well, most of the physicians are either doing the erectile preservation immediately after surgery or after the catheter is removed, roughly 65%. And most of these programs will typically last at least a year or longer. So it's pretty encouraging. So are we treating these men too late after prostatectomy? My bias is yes. So this was a wonderful study by Dr. Mulhall, and he looked at the rate of what we call venous leak after radical prostatectomy. If you study the penile tissue after a man has a radical prostatectomy, 14% of them had venous leak at 4 months, 30 at 8 months, 50% at 12 months. It is a progressive disease. So the longer you wait, the more damage is occurring to the penile tissue. So he said, what are the predictors for returning of erectile function? And the first couple are pretty obvious. If they cut the nerves, you're probably not going to recover as well. If you're using high doses of Trimix, it would probably be hard to recover. Age greater than 60. If you had some comorbidities. But the last one's pretty interesting. If the patient started the penile rehabilitation program later than 6 months after the radical prostatectomy, it was an independent predictor of more difficulty in recovering their erectile function. Dr. McCullough found the same thing. You don't want to wait, and most of us in the industry and the field would believe that 6 months, the first 6 months, is a really important window when we talk about recovery of erectile function. And this is just an animal study, but I think it's important. He gave these animals sildenafil 3 days before, 1 hour before, or 3 days after a bilateral nerve crush injury. What did he find? He found that if you gave the medication before the injury, 3 days before, it did a lot better than if you gave it to him 1 hour before or 3 days after. And typically, I know this is an animal study, but typically we do the same. We like to prime the patient before surgery as opposed to just giving these medications somewhere down the road. Very interesting study also. This is looking at men who had a biopsy of their penile tissue at the time of radical prostatectomy, 2 months after the radical prostatectomy, and 12 months after the radical prostatectomy. And at 12 months after the radical prostatectomy, at 2 months you start seeing significant increase in fibrosis in the penile tissue and scarring, and at 12 months, 60% increase in collagen, which is really scar tissue, and a 65% decrease in elastic fiber. So I'm really trying to stress the point that the clock starts ticking once you have the radical prostatectomy, and as time goes on, the tissue starts to deteriorate. So what's the goal of erectile preservation? We want to improve the oxygen within the penile tissue. I want to preserve the endothelial function, and I want to prevent the smooth muscle changes that are occurring. But I think the most important point is back to baseline. I tell patients, I cannot make your erections better than they were before surgery, right? They say, Doc, I want to have a great erection. Did you have a great erection before surgery? No. Well, I can't make it better than it was before surgery. My goal is to make it at least back to baseline. So many options that you have out there. I'm not going to really go through them because we've already talked about these, but the most common is the PDE5 inhibitors, Viagra-like medications. This is the important one because this is where they gave these patients Viagra 50 milligrams every other day, a Viagra 100 milligrams every other day, or they gave them placebo and they biopsied their tissue, the penile tissue, at 6 months. And so a very important point is that at 6 months, if you got Viagra 50 milligrams a day, you saw no change in the smooth muscle at 6 months. Remember, I told you as time goes on, the smooth muscle starts to deteriorate. But in this study, if they got Viagra 50 milligrams every day, they didn't lose any smooth muscle content. And in fact, if they gave these patients Viagra 100 milligrams a day, they actually had an increase and smooth muscle content at 6 months. Again, suggesting there may be some importance in giving these medications regularly after the radical prostatectomy. We do use a vacuum erection device, but one of the benefits of a vacuum erection device is preserving penile length. Many men after the radical prostatectomy will complain of loss of penile length. The vacuum is excellent in preserving the penile length and the tissue. We tell patients if they can do it for 20 minutes a day, it makes a big difference. Now remember that the vacuum is about 58% arterial, 42% venous. And so I would love to have 100% arterial blood, like with an injection or with a Viagra. So the take-home message is I tell patients, you need to have 3 erections a week, and the vacuum doesn't count. If it's with an injection, if it's with a pill, we want you to have 3 erections a week, but the vacuum doesn't count because it's really pulling in about 42% venous blood. So we did publish something on the female factor on this, and we showed that those men who had women at home that were more likely to want to engage in sexual activity, those men were more likely to be compliant with an erectile preservation program. It makes sense, right? So again, we think it's very important to focus on the female partner because typically a man who does not have anyone at home to engage in sexual activity with is less likely to spend the money and the time in these programs than a man who had someone who wanted to engage in sexual activity. So this is our protocol and our erectile preservation protocol. We start 2 weeks before. We put the patients on daily Cialis. We do give them mousse or compounded trimix gel. We check their hormones. We treat the female partner. After surgery, we put them back on the Cialis, and we do use the mousse. At 1 month, we're pretty aggressive. We will start the testosterone therapy if it's undetectable, the PSA is undetectable. We'll continue the Cialis, and we'll also use the Viagra on top if they need to use for intercourse. At 3 months, if they're not able to engage in sexual activity, we start them on injection therapy. That's typically the time we start the injection therapy. We typically follow these patients with questionnaires all the way at least a minimum of 1 year or longer. So I'm going to switch. My last topic is testosterone. It's a hot topic, if many of you have seen in the news, these low-T clinics. I don't know if you know this, but in 2012, testosterone was the fastest growing medication in the United States. There was not a single medication in the U.S. that was selling faster than testosterone, with a sales growth of 33% per year. The concern by the FDA, if you can look at this line here, is that the testing was going down and the utilization was going up. And what they found was roughly 27% of men in the U.S. were theoretically abusing testosterone. It's possibly so. They weren't getting tested and they were taking it. So again, there is some concern about abuse, but there are some beneficial effects we need to talk about. Remember that starting at age 30, every man in this room started losing 1 to 2% of testosterone every single year. It's not surprising by the time they hit 60 that they would have very low T levels, and they undergo a concept called male menopause or andropause. They feel identical to women in menopause. Low energy, low libido, sexual dysfunction, depression, poor sleep. It's identical. But the men have 30 years to adjust, where women have just 2 years to adjust, but the symptoms are almost identical. How do you diagnose low T? It's pretty simple. It's just a simple blood test and signs and symptoms. So a patient has to have the symptoms and a blood test. The number we typically use in the U.S. is 300. So if you have a blood test less than 300 and you have the signs and symptoms, you're eligible for therapy, but you must have both. So we know that testosterone affects almost every part of the body. It's not just about erections and libido. It affects our skin, our liver in terms of how we make our proteins. It affects our bones. It affects how we make our muscles and also our stem cells as well. So again, it's a very important hormone that does have an effect on multiple parts of our body. So these are the signs and symptoms. Patients walk in, they have increased body fat, reduced muscle mass, low bone mineral density, maybe loss of body hair. The number one symptom that I see in my clinic is decreased energy. Doc, I'm tired. I'm taking naps. The number 2 sign and symptom I see is decreased libido, erectile dysfunction. We may see some diminished work performance, poor concentration, sleep disturbances, and depression as well. And I do want to comment one on depression because I think it's important. You know, in 2011, we published a series looking at depression. We looked at 850 men roughly in the United States. And they all had low T, and we gave them a questionnaire called the PHQ-9, which is a depression questionnaire. And what we found was that roughly 92% of men who had low T had some degree of depression, whether it was mild, moderate, or severe, and 17% of those patients actually had severe depression. And when we treated these patients for 1 year, we found that that severe depression went down from 17% to 2%, But what was more interesting is if the patient was already taking Prozac or Lexapro, those patients also saw a significant improvement in depressive symptoms when we started the testosterone therapy. And so the take-home message, and I tell this to many psychiatrists, is that not many of them are checking testosterone levels before they start the Prozac. You got to check the testosterone level in patients when they start complaining of depression. These are other conditions that are associated with low T. The number one is chronic opioid use. If you take Vicodin, if you take Soma, you see a reduction in testosterone levels within 4 hours after the ingestion of testosterone, these opioids. 50% of patients with obesity, diabetes, and AIDS, 40% of patients with hypertension, hyperlipidemia, and 20% of patients with ED will all have low T. So again, these are the patients that absolutely need to be screened for low T. There are many treatment options out there, and I'm not going to go through all the options, but just to mention that roughly 70% of the country uses a gel. They wake up every morning, they rub a gel on their shoulders, now they go under the arm. There's a nasal spray as well, 70% of the country. 17% will use injectables, 10% will use patches. There is a newer therapy that's been out for about 6 years called Testosterone. Patients will come into the office and they'll have subcutaneous testosterone implants placed into the side of the hip. If a patient has a history of prostate cancer, I don't start with this. I start with the gel first, see how the PSA changes, if there's any issues, because once you put the pellet in, you can't take it out for 4 months. So we typically like to start with a gel first and then move into a pellet. So what is the number one concern about testosterone in the world? The number one concern about testosterone in the world is risk for developing prostate cancer. That's it, the number one concern. It doesn't matter what country you go to, they say, we are concerned that you may develop prostate cancer. Well, where did it come from? In 1941, there is a seminal article, and I want you to pull it from the library, Huggins and Hodges. Reducing testosterone to castrate levels caused prostate cancer to regress. Administration of exogenous testosterone caused prostate cancer to grow. If you pull that article, you will find something very interesting. It's based on one single patient, 1941. One single patient. In fact, if you said, Dr. Khera, can you show me all the articles? Show me all the articles in the PSA era that show that testosterone actually causes prostate cancer, I would not be able to produce that article, right? But it's the number one concern we have in the United States and throughout the world. So, there is no study today, if you look at all the men who receive testosterone, there's not a single study to show that the incidence of prostate cancer in those men getting testosterone is higher than those men not getting testosterone. In other words, the incidence is not higher in those men getting testosterone. I think that's a very important point. We know that many of those men may even have occult, or do have occult, prostate cancer. In fact, the data would actually support that those men with low testosterone levels may be at a higher risk for developing prostate cancer. Not higher, but lower levels of testosterone, more likely to have aggressive prostate cancer and the development of prostate cancer. Several studies, I'll go back one here. Several studies have actually shown that those men with lower testosterone levels are much more likely to have a biochemical recurrence after the radical prostatectomy. Today I'm just showing you Yamamoto's study, but Garcia, many others have shown that those men before radical prostatectomy, if they have a preoperative testosterone level that's low, it's a predictor for that patient to have a higher recurrence of prostate cancer after the radical prostatectomy. There are only 4 studies in the literature looking at men getting testosterone after the radical prostatectomy. 2 of those are ours, the last 2. And I just want to point out that the first 3, there's no increase in prostate cancer recurrence in giving men testosterone after radical prostatectomy. In our 4th study, we did have 4 men that did have a recurrence of prostate cancer. But we did something pretty unconventional. We treated some of these men with high-risk prostate cancer. In other words, they had Gleason 8, positive surgical margins, positive nodes, and we gave them testosterone. And we found something very interesting. In those patients that we gave testosterone who were high risk, the recurrence rate was about 15.3%, which I would argue is pretty low after 3 years. And the biochemical recurrence in those men in the control group was about 53%. So 15.3% we would argue is pretty low, particularly in a high-risk group receiving testosterone. In fact, if you look at all the number of patients that get testosterone after radical prostatectomy that I can count, it's about 386 patients. The recurrence rate is very, very low at 1.5%. And every time we submit this article or these manuscripts, the reviewer always says to me, are you suggesting that testosterone could be protective? Your recurrence rates are too low after giving these men testosterone after prostate cancer. It's an interesting thought. I just want to bring up one thought here. I was able to give grand rounds at Johns Hopkins, and I met a physician by the name of Dr. Den Mead. And do you know how Dr. Den Mead treats men with metastatic prostate cancer? He gives them high doses of testosterone. That's how he treats them. This is an FDA-approved trial treating them with high doses of testosterone. He published a series last year, and this is a series of 14 patients. This is a castrate-resistant prostate cancer, giving these patients testosterone enanthate 400 milligrams IM for every 3 months. And he would put these patients on Lupron. So what they do is they would cycle. It's called bipolar androgen therapy. High doses of testosterone and then bring it down. What he found was that 50% of those patients had a reduction in their PSA, and 50% of those patients had a radiographic improvement in metastatic prostate cancer. And again, what I point out is, 10 years ago this would have been unheard of, but currently this is a trial going on in the United States. This is just a small study from our lab. We do the same thing. We take prostate cancer cells, we put them in petri dishes, and we give them different degrees of testosterone. And I'll show you, you can look at any bar you want here. If you look, as we give these prostate cancer cells testosterone, it is true, you do start seeing growth in prostate cancer cells. But as we give these prostate cancer cells higher doses of testosterone, you actually see an inhibition, a decrease in prostate cancer cell growth. Very similar to the top slide here. A is no testosterone, B is giving testosterone to the prostate cancer cells, and then C is actually giving higher doses of testosterone. So I am not going to tell you today that giving testosterone is safe after radical prostatectomy, because I can't. I'm not going to tell you today that it's protective, because I can't. The reason I can't is because we don't have any randomized placebo-controlled studies. But what I do want to do is I want you to question, is it truly dangerous, right? That's what I want you to question. And that, I think, is still debatable. We have now started the only randomized placebo-controlled study in the country, giving half the men placebo or half the men testosterone after a radical prostatectomy. And we fought pretty hard with the FDA because they wanted me to wait a year to give these men testosterone. And I said, no way, because remember, I think the window is really the first 6 months. And finally, we were able to convince them to let me give it to them within the first 3 months. So as long as a man has 2 undetectable PSAs and a Gleason 3+4 or less, I'm allowed to treat them in my study with testosterone therapy. And finally, we had an eloquent talk earlier on active surveillance. There are only 2 studies on testosterone and active surveillance. One of them was ours. The second one was by Dr. Kacker. This is just a small study of 13 men. A majority of them were Gleason 3+3, 1 3+4. These are men that are on active surveillance and have low testosterone and say, Doc, I know I have low testosterone, and I have prostate cancer, but I want my testosterone back. Is it safe? Hard to answer that question. We did find in our study that we had no significant change in PSA once we started these patients on testosterone, no change in prostate volume, but the key thing was there was no cancer progression was seen in any of the individuals. And when we re-biopsied these patients, we didn't see 54% of them didn't have cancer on the biopsy. And I tell patients and I tell clinicians this, I know that if you treat 60 men in your practice with testosterone, I promise you, you're giving 10 men with active prostate cancer testosterone, because the risk of occult prostate cancer is at least 1 in 6. But these men are not lighting up. And so we wrote in our conclusion of this study, we are only doing openly what many people are doing blindly in their practice, and we found the same results. I think just to point out that testosterone, in my opinion, is extremely important during the first 6 months, and I would argue that a hypogonadal man is at a significant disadvantage in recovering his erectile function compared to a eugonadal patient, and therefore we are pretty aggressive in getting the testosterone early on. Last comments on testosterone therapy for women. Remember that women are different. They make 50% of their testosterone is from the adrenal glands, 50% is from the ovaries. And so typically, many of these women will come in with very similar signs and symptoms that we talked about in men. Decreased sexual desire, fatigue, a lack of sense of well-being, decreased lean body mass, increased fat deposition. Unfortunately, you can't walk into Walgreens and buy testosterone for women. It doesn't exist. It's off-label, right? So you have to use a compounding pharmacy to put it into a cream, and that's typically what we do. We compound the testosterone, or we'll use it in a pellet formulation. We are using new technology now. We're working on nanotechnology. It's a chip that we will implant in the hip, and that chip will slowly release testosterone over 6 months. And the nice thing about it is that you can remote control it from outside the body, increase or decrease the dosage. So if it's too low or too high, you can control it from outside the body, and this is something you'd expect in the future. We also are going to use stem cells. We're injecting stem cells into the testicular tissue and having those stem cells then turn into Leydig cells and have the patient make his own testosterone instead of us giving them testosterone as well. And this is my conclusion. So everything I told you today, I quickly figured out that there are 4 things that can significantly improve testosterone sexual function. It's diet, exercise, sleep, and stress reduction. These are called my 4 pillars. And each one of these have been shown to significantly improve testosterone levels and sexual function. But more importantly, they've been shown to improve mental health and physical health. And I think it's extremely important when you treat patients to have a holistic approach and focus on these 4 pillars: diet, exercise, sleep, and stress reduction. Thank you for your attention.
So before it feels like a press conference at the White House, let me just get my quick questions in. And I'm going to run through a number of them. Thank you. That was excellent. So let's go with the first slide. Okay. So here's the problem that I have had, and you know this because I've talked to you enough about it. I complain about it constantly. I think the biggest killer of erections in 2016 are the price of these drugs. When you see the actual price, I have a friend at Harvard who now tells me his patients are paying $41 a pill. Yeah. That is very likely to kill your erection when you see how much you're paying for it. So, can you comment on price? When are we going to start seeing generic? I heard that Viagra was going generic 2 years ago. So what's the update on pricing, generics, and that area?
Let's talk about it. So there are 3 ways that you can get these medications, right? The first way is through a pharmacy. And Dr. Moyad's absolutely correct. It's extremely expensive. Most insurance companies will not cover it. It can be $30 to $40 a pill. That's option number 1. Option number 2 is through Internet Canadian pharmacy, which I'm not a fan of, but I can mention to you that Canadian pharmacies are typically a pass-through. So we did a study with Oren Goldstein. We looked at 25 pharmacies that we solicited getting the drugs, and what we found was all of them, not a single one was made in Canada. They were actually made in China or they were made in India, and they were passed through Canada and came down. The percentage of the drug is not the same. For example, it says Viagra 100 milligrams. It's probably Viagra 47 milligrams or 52 milligrams, right? Many of these drugs also had lead, paint, bacteria inside the medication. So there's no quality control, and you have no one to track if something goes wrong. Who are you going to call, right? There's no one to go to. But the drugs are very cheap. They can be down to $2 a pill, right? So I just think you have to be careful. But there's a middle road, and the middle road is the compounding pharmacy. The compounding pharmacies can make sildenafil compounded. Many of these can also make tadalafil compounded. They're not as cheap as the Canadian pharmacies, but they're significantly cheaper than Walgreens or CVS. And so typically my compounding pharmacy can make 100, so they can't make the same milligrams. So they can't make 100 milligrams of Viagra. They can make 110 milligrams, or they'll make a 90 milligram, but for patent infringement, they can't make 100 milligrams. So they can make a Viagra 110 milligrams for $4.50, which is almost a tenth of the price. They can make a daily Cialis for $1.50 for 3 milligrams, or 7 milligram for $2.25. So the compounder pharmacies can make a cheaper version, and at least you have someone to go to for quality control if something goes wrong. So I typically try to stay away from internet pharmacies, and I may use more compounding.
And Viagra is generic in South America, is that right?
It is. It's also used for pulmonary hypertension, so you can also use that version, and then you sildenafil. That's correct. Theoretically, it should be generic in 2018, but they keep pushing the date back. Pfizer's able to keep pushing the date back.
I know. I don't know how they're able to do that.
Yeah.
I wonder if more thought leaders spoke up about the price, if that would change things.
Yeah. No, I agree. It's expensive. It's very expensive.
Okay. So at least, in the next few years, we're going to see something like that. Let's go to the next slide, which I asked at the fall conference. So I had a urologist who had prostate cancer and said, man, I love this thing called Staxin. I haven't seen a single advertisement on TV. Yeah. It's a FDA-approved drug for erectile dysfunction. It's half the price of what I was paying for Viagra.
Yeah.
Why doesn't anyone talk about Staxin? So can you tell the story about it? Is it legitimate?
So Staxin is a little bit of a misnomer. Staxin is really just Levitra. It's Levitra at half the dose, at 10 milligrams. So it's a Levitra 10 milligram dose that's made in an oral dissolvable formulation, right? So it's a little bit different, right? So it's placed on the tongue and it dissolves. So it is cheaper, but it only comes up in 10 milligrams. And, Levitra really stopped promoting, the whole entire brand, Bayer, when it started really taking a hit in the market. But if, again, Staxon, just think of it, it's just Levitra. It's a 10 milligram Levitra. It's just a little bit fancier way to get it into the body.
But it's cheap.
It's cheaper, but still, to get the same effect, you'd have to take 2 Staxons to get the same effect as a 20 milligram of Levitra.
But
right?
you use it.
Not as much, because patients find it not to be effective. Most patients would rather take a full dose of Levitra, 20 milligrams, or Cialis 20, or a Viagra 100. So it's almost like a half dose.
Okay. Let's go to, before we go to the next slide, hold on one second. You were talking about the female sexual dysfunction pill.
Yes.
Now, this thing was incredibly controversial.
Yeah, I agree.
Right?
Yes, very controversial.
And now let me show you in Mohit terms the actual article that just published in a journal and their conclusion of all the studies that were done with this drug before it was FDA approved. So can you bring that up? I think it's the next slide. No, one more. Okay. 5 published, 3 unpublished trials with over 5,000 participants. Treatment with this drug on average resulted in 1/2 additional satisfying sexual event. I want you to define to me what 1/2 of a sexual satisfying event is. Because at the Mohit house, it's always more than 1/2, I can tell you that. While statistically and clinically significantly increasing the risk of making you sleepy, dizzy, nauseous, and fatigued. Now that is making me really hot right now. My wife is reading that going, that's what I want to take that for my husband, so I can become dizzy, sleepy, nauseous, and fatigued when I make love to my husband. Overall, the quality of the evidence was great. It is very low. Just published. What do you think?
So first of all, they're only showing you 5 published, so there were well over 5 published, and it was well over 11,000 women that were studied. So this is just a subset of what they're showing you here. It is true that some women can get dizzy, somnolence, nausea, fatigue, but what drug can't, right? Viagra has much worse side effects than that, right? And when you give these patients that, those were really not that severe. I prescribe quite a bit of ADE. Now, I will tell you this, not all women respond. That is true. Not all women respond. There are some patients that will get a good response, some patients that will not get a good response at all. So there is some controversy in the efficacy. And to me, it's kind of like a hit or miss drug. If you take it and it works well.
How much time do you give it, though?
Typically, I give the patients 3 months.
Okay.
And so typically, she'll start it, and I give her 3 months. The only caveat is that they didn't finish the drinking studies, the alcohol studies with it. So you are not allowed to drink alcohol with it. So many women say that's a deal breaker. I'm not stopping. Right. I'm not stopping my wine. But you are actually so much so that the women have to sign a contract in the office saying they will not drink alcohol while they take ADE.
Really?
Yes.
Well, that's a bummer. Although some of us get more good looking when women drink. So, all right. So, is there anything else coming around the corner besides? Well, let me again. I just want to be honest, but at the same time, it's controversial, but just honest.
Yeah.
There was a huge campaign behind this.
There was.
They involved patients.
There was.
Patients were used as pawns. Sometimes they're used as pawns in this game in terms of advocacy. So what did this incredible company named Sprout Pharmaceuticals do? The moment it got FDA approval and they said, we're here for you, we love you, they sold it for $1 billion the first week after it got approved to Valiant.
The next day, yeah.
Right. I mean, it does have a creepy oiliness factor to it. So, your comment.
Well, the reality is this, that, the FDA, there was some politicking going on, and I agree, but what drug doesn't? I mean, the reality is that every single drug, whether even Viagra, Levitra, Cialis, politically there's a movement. But one of their arguments is that, look, every time they bring up a female sexual drug to the FDA, with good data, it always gets rejected. And every time you bring up a male sexual dysfunction drug with minimal data, it gets approved. Right? And so the argument that they use that as one of their bases. They said, look, you got to be fair, right? And that's their argument.
Okay. Let's go to one of the first articles that restored my faith in humanity I read. It was from Clinical Evidence. You had written this article of state-of-the-art treatments for sexual dysfunction. Can we go to that next slide? No, go one more. This is all you basically said. You said Korean red ginseng and some of these other products do have some evidence.
Yeah.
So it's not all about the prescriptions. There are a few things over the counter. You said this in a clinical evidence-based journal that teaches doctors with
Yes.
Goldstein.
Yes.
And I highlighted that when I teach. And I say, look, these are the guys who teach the course. They're saying that there are some supplements over the counter that can help men. Can you comment on that?
There are some, and they've been shown in placebo-controlled studies, and there's very few, but arginine, ginseng has also Korean ginseng as well. Carnitine and citrulline have also been helpful. If you think about the equation, arginine plus carnitine plus citrulline actually equals nitric oxide, right? And so typically we find this to be very beneficial. And typically we'll use these medications to help with blood flow to the genitalia, but it helps with blood flow throughout the body. But we typically do use arginine, carnitine, citrulline, and ginseng for men to help with blood flow, penile blood flow.
So you combine them with the prescriptions?
I do, as a
Okay.
separate supplement. There are some companies out there that actually put them all in one pill,
Yeah.
which makes it easy. But we typically will ask them to use these medications as a supplement.
Okay.
Yeah.
Then let's go back to the Time magazine photo. Let's go back to, I think it's back, there you go. So, testosterone replacement therapy, if you stay up late enough in Los Angeles or in Ann Arbor, Michigan, of course you always see lawyer commercials. But I'm seeing a lot about if you were taking testosterone replacement, call the law office of a so-and-so, because if you've ever had a stroke or a heart attack. So do you want to comment on that?
do.
Because right now we're just flooded with this concept that if you go on testosterone, you're very likely to have a heart attack and get ready to sue.
Right. So let's talk about that. Before 2010, I got to put you back in time. Before 2010, there were numerous articles showing that men with low testosterone levels have an increased risk for heart attack or stroke. In fact, there are many studies showing that giving testosterone supplementation may improve cardiac function. There were roughly 49 published journals before 2010. In 2010, a study by Dr. Basaria came out with an article looking at men in a nursing home over 74 years of age getting high doses of testosterone, and what they found was that some of those men had an increased likelihood of having a heart attack or stroke. Now, there were some flaws with the study. They were getting high doses of testosterone. They were 74 years of age, and it wasn't ever intended to study cardiovascular events, but that's what they found. But what the clincher was in 2013, a woman by the name of Vegan came out with an article saying that testosterone may cause a heart attack, and that was in December. And in January of 2014, Finkel came out with an article saying that testosterone may cause a heart attack or stroke. These were non-randomized, non-placebo-controlled studies. But because those two studies were a month back-to-back, the FDA said we're going to start an investigation because two studies came out back-to-back saying there may be a heart attack or stroke. Well, I didn't realize this, but if the FDA starts an investigation on a drug, lawyers put out ads to capture patients so that if it goes to trial, I didn't know this, they sell the patients to the people who go to trial.
They sell the list.
They sell the list,
Right.
So the ads went crazy in March of 2014.
Yeah.
Crazy, right? And so and that went on for a while. There was a hearing in September of 2015, which I was at, and we 14, where the FDA said, look, we do not have convincing evidence to support that it causes a heart attack or stroke, but we can't say that it can't either, right? Until more studies are done. So they put it in the package insert as a potential risk for heart attack or stroke. We are starting now a huge multi-center trial looking at this issue. But again, it's in the package insert as a potential risk until those studies are done.
Do you know what's worse than a busload of trial attorneys going off a cliff? An empty seat. Sorry, when are you going to realize the conference is my therapy? That's all it is. It's just my therapy. So here's the concern I have. When you go on LHRH, when you go on hormone suppressive drugs and you go on them too long, a lot of patients don't realize even if we take you off of it, you'll never make testosterone again.
Or you won't
right?
rebound. You won't rebound back to your. You may not rebound back to your baseline. That's correct.
Right. You'll not rebound your baseline, but this is a percentage.
Right.
Some people will not be able to make testosterone again. You won't rebound to where you were. So now I think the antithesis must be true, that when someone depends on testosterone for too long, the testicles shrink.
That's true.
And then they don't make testosterone anymore. One testicle talks to the other and says, what the hell's going on here? You know, we're getting this exogenously. Why do we need to make this stuff? In my world, they talk to each other, the testicles. And so I heard stories that 3, 4, 5 years out of TRT, testosterone replacement, the guy wants to come off and he's not making it anymore. Is that true?
So 2 comments. One is, your point's well taken. One, testosterone does shut down your own natural testosterone production, but more importantly, it makes you infertile, right? So remember that if someone is in the reproductive years and they want to have kids and you're giving them testosterone, that's not good, right? You don't give someone testosterone in the reproductive years. Many patients and clinicians don't know that, right? But as long as you treat men with testosterone, for the longer you treat them and the higher the dose, you're right, it's more difficult to reverse them. We have a protocol at Baylor that we do use. We give them HCG, 3,000 units, 3 times a week, which is just an LH analog. It's just a medication that pushes the testicles to make more testosterone. And we show that we can have recovery of sperm function and testosterone on average of 6 to 7 months if they're azoospermic and have low T. So we can recover them, but it takes some time.
So these are legitimate testosterone increasing options that don't involve testosterone directly.
Right, exactly. Right? HCG 3,000 units every other day.
So people should be asking about that also. I think I'm actually done with my slides, but the one thing I want you to comment on, because I got asked one more thing before I go to these questions, is when we used to go to the meetings 5, 6 years ago, they talked about nerve grafting. That we were going to be able to take a nerve from one part of the body, from someone that had a radical prostatectomy, place the nerve somewhere in the penis, and you were going to get erections back. And there was all this excitement, and then suddenly there was nothing there. What's going on?
So it started at Baylor. The sterile nerve graft was with Scardino, and we did quite a bit as a resident. The issue was it did not tend to be as effective as we thought.
Where did you take the nerve from?
It was sterile nerve. It was a sterile nerve.
You took it in the back of the leg?
Yes. And then later on you started using synthetic nerves, like nerve grafts that we would take. Yeah. But I would tell you that probably in the past 5 years, I haven't seen one of the clinicians, particularly at our institution or others, do it.
That's too bad. There was tremendous excitement there for that. So, all right, I think I got through my therapy, and then so we're going to do questions again. Pithy. Make sure the question helps the rest of the audience. Feel free to mention your name, address, how we can find you when you ask the question. So let's go to this gentleman right up here, and then we'll go left to right. There you go. Hold on, let me make sure you get the microphone.
Excuse me. How about ED relative to hormone therapy?
Androgen deprivation therapy?
Right.
Sure. So it's so very important. So the level of testosterone in the body works at different levels with different body parts. Let me explain. Typically, if you look at studies, when man's testosterone falls below 200, he starts losing his nocturnal erections, right? So we know that when you give testosterone to men, and their testosterone, Lupron to men, their testosterone levels fall below 200, they lose the nocturnal erections. It becomes much more difficult to obtain an erection. I think the nocturnal erection is a very important one because if you did a blood gas on a man's penis during the day, it's actually in a hypoxic state. It's actually somewhat contracted. And those nocturnal erections are nature's way of preserving the penile tissue. So again, I think that the Lupron does hurt the nocturnal erections, but also hurts your ability to obtain an erection.
Okay. As we go to this gentleman over here with the microphone, I want to, if someone had to leave here in 2 minutes and said, look, I'm about to have a procedure of some kind. I'm going to go on Lupron. I'm going to have surgery. I'm going to have radiation. And I want to be on the ideal penile rehab program. In general, what would you recommend? Do you recommend it for most patients, some kind of penile? I know you didn't like the word rehab. I'm sorry.
Erectile preservation.
I know, but I've been using rehab forever, so I can't get it in my brain. So tell me what you would do.
So I just want to put this in context. There is some controversy in our literature on the efficacy of erectile preservation medications. So you should know that. One of the largest studies by Dr. Montorsi, the reInvent study, showed that there was no benefit in giving Levitra versus placebo. So there is some controversy. So there's a group of us that say we believe in it, there's the group that don't. So I just think it's important that you know that. There needs to be more studies. But I think that daily Cialis, where I showed you the study with the sildenafil as well, actually tends to be myotrophic. We know that in animal and human studies as well. It increases the smooth muscle content within the penile tissue. To me, that's extremely important because the cause of ED after radical prostatectomy is atrophy of the smooth muscle. So anything that causes hypertrophy of the smooth muscle to me is important. So a daily PD-5 inhibitor is important.
So daily starting when treatment starts or right after treatment or before treatment starts?
I start 2 weeks before.
You start 2 weeks before?
I start 2 weeks before therapy.
And that includes radiation?
Even on radiation, I use it 2 weeks before and after.
Okay.
The protocol is the same. The only difference is that those patients after radiation have a much better erectile function than those after radical prostatectomy, so they don't not so dependent on intracavernosal injection therapy. But I don't use the testosterone in men after radiation until 18 months, and I do a biopsy first,
Okay.
right, until they're at the nadir.
And then what about for Lupron or LHRH? Do you tell them they should also take daily Cialis when their hormones reduce?
Absolutely. Absolutely. It's a phenomenal medication for providing blood flow and oxygen to the penile tissue, whether you're having sex or not. Every day it's putting blood and oxygen to the penile tissue.
Because all these treatments reduce the length and width of the penis, right?
Radiation
the surgery,
right? So that's the second point.
And that should be mentioned before the treatment.
It is a side effect. The other thing is, if you were to choose two things, it would be the daily Cialis and the vacuum erection device.
Okay.
The vacuum erection device is a tissue expander. That's all it is. Every day, you can put blood and oxygen to the penile tissue, but you preserve the integrity of the tissue, right? And so it prevents atrophy. And it's the only thing that's been shown to not only prevent, but actually in some cases increase penile length after a radical prostatectomy.
So daily Cialis, vacuum erection device.
Those are, if you say, look,
Those
tell me
two.
the bare minimums.
Well, I
Those
like
would be
that.
those would be my bare minimums after any kind of radiation or radical prostatectomy.
Okay.
Great. A comment and question, if I may. Hey, Mo, how you doing?
Oh.
The comment has to do with ADYE. It's important to note that the drug is designed as a drug for low libido in women, distressing decline in sexual desire. It's not a drug that's designed to increase satisfying sexual events. And in terms of the endpoint that they were really looking at, it did perform somewhat better than that slide would have you indicate. So it certainly has its problems. With respect to the question, in terms of the symptoms of low testosterone, it's a pretty nonspecific list. So do you have particular things you ask about or other comorbid conditions you would inquire about before going to the testosterone to look at sleep apnea, weight loss, et cetera?
Sure. So very important point. Alan, good to see you. Listen, there is, if you look at the studies, you're right. The signs and symptoms of low T are nonspecific. Low energy, low libido, depression. I mean, it's not specific. But if you look at the most, one of the most famous studies was the European Male Aging Study. Fred Wu showed that if a patient had these three things, which were low sexual desire, ED, and loss of morning erections, those three together had the highest prediction of truly having a low testosterone value. So those are important. The sexual side effects are very important. But your point is well taken. You know, many of the causes for low T are actually induced by obesity, sleep apnea, metabolic syndrome, maybe you're taking chronic opioids. And so one of the best ways to treat the low T is to treat the condition, right? If they get the CPAP machine, a CPAP machine has been shown to independently significantly improve testosterone levels in men, right? Weight loss significantly improves testosterone level in men, right? So we know that if you can treat the condition, even insulin resistance, if you improve the diabetes, put the patients on metformin, the T levels start going up, right? So these are very important concepts in treating low T.
Great. Yes. Can you pass that to him, and then we'll pass it up to here. Thank you.
My name is Carlos Yules from Santa Monica. What upsets me about these meetings and the way you discuss it is that 70% of low T is secondary hypogonadism. And yet you're not dissecting out who's got primary versus secondary. And it's pretty easy to do. You can do a baseline T, give them HCG for 3-4 weeks, and see if their testosterone doubles or triples. If it doesn't, they've got primary. But yet these discussions over and over, and I've been to many meetings where that's never been discussed. Now we have a drug before FDA, Repros, which is then clomiphene, the trans-isomer of clomiphene citrate, which we know is a very safe drug. It's been around for 30 years or more, used in women, off-label in men. That is a drug which should have been approved years ago. The phase 3 trials are very good. But I am upset that we don't talk about that. When you say opiate withdrawal, well, what are you doing? You're treating a secondary hypogonadism, not primary. Once you've got primary, your testes are gone. Please comment.
Yeah, all very good
Well, let
points.
me first comment. He has an hour to cover a subject that he could give a lecture on for 12 hours, so we have to be a little sensitive to that. So this section is kind of a little hostile. I'm a little concerned about this. You might need to put some tape right here. So So go ahead.
So just a
Yeah.
quick comment. So
This
so
is
what
my
you're-
homie now. Don't mess with this guy.
What he's referring to is, look, when someone has low T, your job is to figure out, is it a problem from the brain not sending a signal to the testicles to say make testosterone, or is it a problem with the testicles themselves not being able to make testosterone? It's called primary or secondary hypogonadism. And so we do that. Every time we see a patient, we have to say, is it a brain problem or a testicular problem? And I think it's very important. But most patients, as they get older, start decreasing their ability to make the testosterone. You can use medications, as he's mentioning, called Clomid. These medications actually increase the signal in the brain to say make more testosterone, and the patient makes more testosterone. It's a more natural way of making testosterone, absolutely. The patient's able to make his own. Realize that the testicles start to fail and die 1% to 2% every year starting at 30. There will become an age where the testicles will say, I don't care how much Clomid you give me, I can't make any more, right? That does happen, right? And so again, I agree, there is a drug that's on the horizon that may be beneficial, and hopefully it'll get approved.
Okay, so we had someone here. There, sir.
I was just going to say, in reference to the Canadian pharmacies, I agree with you. A lot of them are, I wouldn't do business with, but I think there are some. I found one company that actually mailed me Viagra from the United Kingdom, and it had the Pfizer symbol and the whole thing, and I don't think it was baloney. So it is possible. But last time I ordered, and it wasn't recently, it was about $15, and I believe it was the real product.
I think that's important. I think the only thing is we can't verify that. There's no way to know, right? And that's what makes me a little nervous.
Well, I think the message is Canadian pharmacies, just Canada's a problem. I mean, that's, I'm sorry, you're still here? Oh my God, I'm sorry. But no, the beer and the hockey, love it. Love the beer and the hockey. And we brought you here, so. So go in the back. Before he asks this question, let me make this clear. The reason some of these questions come up in the fall meeting is that patients have to leave this meeting, and professionals, with both sides to the story. I could give a damn what side you take, but they have to hear both sides. So yes, maybe that first slide on the female product, I want to make sure they understand the controversy as well as the benefit, and then you get the final word. But I don't want to walk into a place where someone only gives me the pro or only gives me the con. I have not done my job, right? So that's why all these questions, I love these questions because I want to hear both sides. What's the side I can't read about in the paper, and what's the side that's beneficial that I'm missing? So, sir.
Is it dangerous for the T level to get too high if you're taking a supplement, for example?
Well, there is some danger. Truly, if the T levels get too high, you can start getting conversion into something called DHT, dihydrotestosterone estradiol. You can start getting gynecomastia, breast tenders. You can get alopecia, loss of hair. We also know that some patients can get roid rage when the T levels get very high. Depending on what type of testosterone you use, if you're using oral methylated testosterone, you can get injury to the liver as well. But if you said to me, some people get to 1,200, 1,300, how high is too high? And I really can't answer that question because there's not a single textbook that says 1,500 is bad, although empirically we think it's bad because it's out of the range, but some patients do sit at higher levels. Remember, the body could care less what the total testosterone is. It only cares about the free testosterone. So if your SHBG, or sex hormone binding globulin, is elevated, then you may need a higher testosterone to get a normal free testosterone.
The other side effect of too high a testosterone is you win 7 Tour de France's. I wanted to add that. You missed that. Next. Yes, this gentleman right here.
As far as these different remedies, you've been talking about erection primarily, but what about the loss of sensation or pleasurable sensation that someone can experience due to going through radiation and hormone therapy?
So it does happen. I mean, let's be honest. So there are patients who will complain of penile numbness, a decreased sensation. We typically will do a biothesiometry test, which is a nerve conduction test to check the sensation externally to the genitalia. And some of these men are going to have decreased sensation. what I tried to explain to them is there's not a magic bullet or treatment for that. Truly, I do believe, again, using daily PDE5 inhibitors, increasing blood flow and oxygen to the penile tissue intuitively makes sense to me. Every time I do a penile prosthesis surgery, we have an IRB to harvest the smooth muscle, and we bank it, and we study the tissue, the penile tissue. Some of the highest density of receptors are testosterone receptors within the penile tissue. So we believe that if these patients have low T, giving them testosterone may help also with the recovering of their nerve and sensations of the penile tissue. But again, there is not a magic bullet for that treatment. It does occur, and it's a real problem.
Hello, doctor. Is Clomid safe and well tolerated?
So Clomid has been around for many decades. Andy Gay, who was a famous endocrinologist, passed away 2 years ago, had 30-year data, long-term data on patients taking clomiphene citrate. Remember, we've been using clomiphene citrate in women for decades, right? It's used as a fertility drug for women, and it stimulates the ovaries, right? And by that same mechanism, it stimulates the testicles, right? And so currently a company called Repros has a drug called Androxyl, which they're trying to get through the FDA, which is just the trans isomer of Clomid. They're basically trying to legalize Clomid so you don't have to get it off label. But it's a very effective and it's generic, so it's pretty cheap.
Can you pass that
That was a great talk and quite balanced, but I just want to make one comment about the testosterone replacement, which is a field I've been somewhat involved in from the other side. And first of all, the pharmacies. So these Canadian mail-order pharmacies are definitely in the gray zone from a Canadian perspective. Some of the doctors involved with them have lost their license because of their connections, so there's nothing for me to really defend there. But just be aware, it's not something that's kind of widely approved. So the issue I have with the testosterone replacement story is that although you, I thought, very fairly made the comment that, we can't be sure it's safe. The rhetoric, that's not the rhetoric. The rhetoric is it's safe. And you see this everywhere. And you can see by the curves you showed of the increasing adoption. By the way, Canadians are the highest users per capita of testosterone replacement in the world. The idea that there may be some risks that we haven't that we don't know about is not communicated in the marketing and to patients. And the example that is completely germane is the hormone replacement therapy story in women, based on smaller studies, very analogous to what we have for testosterone replacement, was said it was safe. It wasn't until they did the Women's Health Initiative study, something like 32,000 women randomized, that all the risks of hormone replacement therapy came out. And we just don't have that for testosterone replacement. The other point is the idea that it has no impact on prostate cancer is not cast in stone. There's some studies, I'm sure you're familiar with them, that do show there's an increased rate of diagnosis, an increased rate of intervention, like TERPs, PSA goes up. I mean, there's evidence that it has an effect. And while I'm not saying it is bad for prostate cancer, all you need to have is one cell that has a specific mutation that means it's stimulated by higher levels of testosterone to proliferate or invade, and you've got a problem. So to say this can't happen or doesn't happen, to me, is not legit. So I just want to make the case that for the right patient, it's fine. But if the idea is that this should be broadly used for all kinds of men with these non-specific symptoms whose testosterone is just on the low side and there's no risk, to me, is not acknowledging the uncertainty.
I think your point is well taken. I think that's why I stressed that one slide where I said, I cannot tell you that it's safe, and I cannot tell you that it's protective. And the reality is we don't have any randomized placebo-controlled trials, not one, to say that it's safe or unsafe. But I do one thing. When I do treat patients with testosterone after radical prostatectomy, I consent them. And in the consent, and this is with the help of the Baylor lawyers, they said you need to put in there that the risk of prostate cancer recurrence and progression is unknown, and the patient states he still wishes to proceed, because that's the truth, right? And so that's what we typically counsel them on. Yes?
We have a microphone up here.
So when we take testosterone cream, for example, you have an absorption versus time curve and then a dissipation versus time curve. And so is there a time of day that is optimal to take the cream so that you get the maximum effect of that curve?
So 2 points. One is that these creams and gels all depend on skin penetration. So this is the formula. It's milligrams times percent penetrance equals your blood level. So if I give you this amazing cream that has 1 million milligrams of testosterone but 0% penetrance, you get nothing. Right, absolutely nothing. So what these creams depend on is they hope that you get about 10% penetrance. And 90% stays on the skin, 10% gets penetrated. That's how they calculate their levels. So, that being said, the problem with a lot of the compounding creams is they have a very poor penetrant. It's a very poor penetrant. And if you have a poor penetrant, you're going to have to switch it to something else that has a better penetrant. So I think the take-home message is that that's number one. Number two is that most of these creams and gels peak in 5 hours. The half-life of testosterone is about 100 minutes. The way they work is they sit in the subcutaneous tissue in the fat, which serves as a depot, and it slowly releases over the time of day. But if you check someone's level, let's say they put it on in the morning, and you check it on the level at 6 in the afternoon or in the evening, it's almost back down to baseline because these dissipate pretty quickly. So I always thought these drug companies should have made these a BID dosing if they really wanted to make it last the entire day, right? Most patients actually engage in sexual activity in the evening, right? And their levels are pretty low in the evening. But theoretically, the best would be a BID dosing, and if you want to check it, you check it 5 hours after application for the peak.
One of the people you write with runs one of the journals, Goldstein. He actually he addressed a number of doctors many years ago at a conference, and he said something very interesting, which I never forgot. He said, "I can give you a gel, and everyone could be happy or not." Or he said, "I can give you an injection, and it might increase my risk of a lawsuit." And what he was referring to the fact is that when you take the gel or you take these creams, you know, physiologically testosterone goes ups and downs. There's waves during the day, right?
Yeah.
But when you give the injection, it goes up and it stays up and then kind of drops down. It's not physiologic. It doesn't mimic what really happens.
Right.
So do you believe that stuff, or do you really care?
So that
which
comes up
one?
in all our conferences, you know,
Right.
the diurnal variation.
Right.
And so is the diurnal variation important? There's not a single study to show that diurnal variation matters. Right? There's not one to say that is those patients that need diurnal variation or not. In fact, you lose diurnal variation between the ages of 40 and 50. So you look at a 70-year-old guy, there's not significant diurnal variation at all. Right? So the younger guys have a lot of diurnal variation. After the ages between 40 and 50, it doesn't really matter as much whether you check their blood levels for screening in the morning or in the afternoon. It's relatively about the same. And the patients that need the testosterone the most are the older guys above 50, right?
Yeah.
So typically we're not so worried about that. But the injections is a good point. I don't like using 200 milligrams of testosterone every 2 weeks. It's a huge spike and a huge crash. So then what we started doing was we started using 100 milligrams every week. A little smaller spike, a little smaller crash, because the half-life of the drug is 8 days. But now what we do is we actually use 50 milligrams Sunday and 50 milligrams on Thursday, because you're getting it twice a week. You get this amazing baseline, because it's an 8-day half-life, with little peaks and troughs on top of it. And off-label, we actually use it subcutaneously because it's such a small dose.
So are these patients injecting themselves, or are you injecting them?
We don't have the resources to inject them in our clinic, but we teach them in the office, and most guys can say, yeah, I can use a small 25 gauge needle and put it into the fat. It's easy. And then you can do it every Sunday and Thursday. Very nice level with minimal peaks and troughs.
Okay. Next question, over here. We have two on this side. If we can pass it down.
Yeah, hello. I'm 25 days out from robotic prostate cancer removal. And a couple observations. One, I went into the surgery very healthy, extremely healthy. All good numbers, in good shape. Had the surgery, came out of the surgery, and was prescribed 2 20-milligram Viagras a day for 30, 60 days. I'm on my 25th day now. So daily I am working, you know, that area. My wife can't help me daily, but, you know, every so often it works good. And then I was recommended to go to Costco and was able to buy a generic brand for basically $7 for 100 milligrams and continue to use that every day. So I'm very pleased with my activity. I'm about 50% 3 weeks out of what I was before, and hopefully the long-term effects of all this will be that I can get back to where I was before.
And I'm glad to hear that you're using it daily, because to me that's really important.
Do you want to comment on Costco?
Well, you know, I'm surprised to see that Costco made a generic for $7. I mean, I learn something every day. I didn't realize that they actually offer that. Because typically the generic is made from a compounding pharmacy where they cannot make the same milligram dosage. So I didn't know they could make a generic for so cheap.
I'd like to ask you at Baylor, what are you doing with active surveillance, understanding that nobody knows for sure? What are you doing with men with active surveillance as far as giving them testosterone? What and how high dose, low dose? What do you do about watching the PSA movement? Could you comment on that for, I think, a lot of people in the room, and certainly for me?
It's a good question. You can get it.
Yeah, typically we'll treat only 3+3 patients with at least 3+3. It's an extensive discussion and a consent, again saying that the risk of prostate cancer progression is unknown, and we do consent them. But after we start them on testosterone, we don't treat them any different than we would treat any other patient on active surveillance on a protocol. Right? There's nothing different that we would do. You would biopsy them the same if you would biopsy them. You would not biopsy them. You would do the same protocol you would. The only caveat is this. If a patient starts out with a very low testosterone level, typically under 200 or under 250, this is called the prostate saturation model. What happens is they actually see they may see a slight increase in PSA, about 0.3 nanogram per deciliter. That was in our study. So we do allow them 3 to 6 months to basically reequilibrate their PSA, and at 6 months then we'll start saying, okay, we treat them just like any other active surveillance patient. Nothing different.
You know, everyone comes in with their shtick and their opinion, right? And I have mine on the testosterone. My opinion is, if you look at the original studies that got testosterone approved in this country, and then you started seeing all the ads, I found it very interesting. I calculated these, as many as I could, and I calculated that the average body mass index in those trials was 30. So the average man who was in a testosterone replacement therapy trial with the companies was obese. So the reason I find that interesting is because I think a lot of people come in, they have low testosterone, but I don't know if they're told. The ones that I see are not always told, hey, maybe if you lose a couple of pounds, you might see a 50, 100-point increase.
Yeah.
And so do you want to comment on that? It's a very targeted population.
So the majority of patients that come in, if you look at the package insert for testosterone, it says it has list diseases that are on label, which means a pituitary tumor, vanishing testis syndrome, injury to the testicles. Those are diseases that are listed. The reality is that only 15% of the patients that we treat actually have those diseases, right? Actually, 85% don't. And that's why the FDA was a little concerned. Basically, we're just saying you're treating 85% of patients off-label. Of those 85% of the patients that don't have a specific disease, the majority of them actually have comorbidities such as obesity, metabolic syndrome, diabetes. And so you are absolutely correct that correcting those conditions can improve their T levels. But the problem is that when a patient walks in, he says obesity, diabetes, low T. And I said, look, you can start a diet and exercise program or you can take testosterone. 99% of them say, just give me the testosterone, right? That's what they say. And I say there's, more importantly, there is truly a synergistic effect with testosterone and diet and exercise. Right? If you take the testosterone and just eat potato chips all day and watch TV, it's not going to help you very much. But if you take the testosterone and you do the diet and exercise, it helps tremendously, and we could potentially take you off the T later on.
Exactly. 99%?
I mean, it's very hard to get someone to come in and say...
They're responsible for probably that. But I agree with you. But I also think it's a matter of disclosure, right? I think it's what you sell. Yeah. And I think with shorter time, 7-9 minutes, you know it is at Baylor, at Michigan, shorter and shorter time, it's so much easier to write the script than it is to counsel.
Yeah.
Yes, sir. Right there, that's fine.
Is there an auto-injector for a Trimix? I heard it.
There is
What
an
are the pros and
auto-injector.
cons of
There's two types. There's an auto-injector where you can, you place the box, basically fill up the solution and put the needle into the box. You press the button and it actually injects the medication, but then you have to push the plunger down. That's option number one. And then there's another one that actually puts the needle in and pushes the fluid in for you. And it helps with a lot of patients who are needle phobic, right? Because you don't have to see the needle, you don't have to deal with it, and just put it there. There is some concern, there was some discussion on maybe it increases more trauma, and it could be more likely to cause a plaque in Peyronie's disease. I don't think that data is well founded, but that is the con that's been in the discussion. But again, there are many patients that use it because they are needle phobic.
Thank you.
Is it true that when you have BPH or prostate enlargement, Cialis has that dual, it's FDA approved for not just erectile dysfunction,
Right.
but also BPH.
Yeah, absolutely.
So there's that commercial, the man in the movie theater and doesn't have to use the restroom, and he's going to have sex later that night because he takes Cialis. Is it true that insurance covers the Cialis for the BPH part, but for many men, not the erectile dysfunction
So
part?
that is true for some insurance companies, but you have to do a prior auth on all of them, so it takes some work on the office's part to get the prior auth done. You have to fail an alpha blocker, so you have to say, I've tried Flomax, it failed, now I take the Cialis for BPH. The office does a prior authorization. If it gets approved, yes, then they'll give you 30 pills a month for BPH in many cases. The only thing is that if you say, what is the mechanism for Cialis for BPH? It's written as mechanism unknown. It does work, but mechanism unknown. But it's much more effective, in my opinion, for symptoms such as urgency and frequency, right? So for the LUT symptoms, it's not great for the flow and the hesitancy side, but it's definitely better for the urgency and frequency. Yes, it's pretty effective.
Interesting. Yes, over here we have a couple hands up here. We got just a couple minutes, but I think we'll get through this.
Does masturbation have a place in penis rehabilitation or maintaining blood flow? My mother told me something about something would fall off if I did it.
Or blindness.
Hey, I was told that story too. Hey,
Yeah.
they said it
Yeah.
would fall off and you wouldn't be able to see. You'd go blind. So that's why I have
Yeah.
trouble moving around here.
Yeah. It's extremely important, and again, it's as I mentioned to the patients, 3 erections a week. It doesn't matter how you get them, but you have to have 3 erections a week. So masturbation, extremely important, and it's really putting in 100% arterial blood. It's preserving the integrity of the tissue, and it's important. It's very important.
Well, I think, can you comment? That's a great question, because I think a lot of people think, what I've noticed, and this is what Mohit told me too, is that a lot of people will take Viagra and then they'll stand there and they'll look at their penis waiting for it to get hard, right?
Which won't happen. Yeah.
And they're not told. Many of the failures are educational failures.
Yeah,
Do you agree?
I agree,
So can
yeah.
you explain that? There has to be
Yeah.
stimulation, self-stimulate something, right?
Absolutely. So you cannot take Viagra and expect there to be an erection. You have to be stimulated either mechanically or physically stimulated in order to get an erection. So that's important. So that's an education issue. The time of day you take the Viagra, before or after a meal, is a big one where people think the Viagra failed, is important as well.
But all these guys on rehab after radical prostatectomy, they'll come to me and they'll say that you have to have stimulation down there. They're just taking it every day. They're told to take it every day.
Yeah.
And then I say you have to have stimulation. They go, what are you talking about? I'm just taking it as a preventive.
Right.
Right?
Right.
But in that case too, there has to be stimulation.
You have to have stimulation. And again, the number we try to tell patients is 3 erections a week. 3 rigid erections a week is what we're trying to strive for.
Okay. Yes, there was a question up here.
For men who have on hormone therapy,
Yes.
excuse me, here.
Where?
Sorry.
Oh,
For
sorry.
men on hormone therapy, you recommend Cialis, 5 milligrams a day, to preserve the penis. But I'm wondering, you mentioned also the pump because sometimes you get penile shrinkage. So I'm wondering how long one has to do that it's not forever, so like is it for a month, 2 months, 3 months to get it, to keep the original?
Yeah, so most of the studies were done for 6 months. So what they were doing is 10 minutes a day, every day for 6 months, right after the radical prostatectomy. But although I would argue that, as a preventative measure, we tell patients even after the 6 months, at least 3 times a week, if you can still use it for 10 minutes, 30 minutes a week, it does help. Because look, even at the natural process of aging, let's say you never had a radical prostatectomy, right? The fact that when men start getting ED, the number 1 age, roughly 54 years of age. agents. Why? Because their wives have gone through menopause, right? So once they stop having sex, guess what happens? They start getting atrophy of the penile tissue, right? And so if you're not using it, you're going to get atrophy. So every man's going to get ED irrespective of having surgery or not, and using the vacuum is a great preventative measure for preserving penile length.
I have 2 rapid fires for you before I take one. This is probably the last question, maybe 2 last questions. At these conferences, they constantly mention venous leak. Someone goes, what the heck is venous leak? But venous leak is a cause of real concern.
Oh, yeah.
So explain venous leak and how you fix it or not.
Sure. So think about, the penis is actually a very clever system. I want you to think about this. There's a tube that has muscle in it, and in the periphery of the tube is the veins. All the veins are on the outside, right below the casing. In the center of the tube is an artery, right? So as the blood comes in, it expands the muscle and it presses the wall and prevents the veins from taking the blood out. So the more the blood comes in, the less the blood comes out. The problem is, as men get older, they get atrophy of the muscle. The muscle becomes atrophy, less muscle. So when the blood comes in and the muscle tries to expand, it can't press the walls to prevent the blood from coming out, so the blood comes out just as fast as it comes in, right? So you can't maintain the erection. An erection is a very simple concept. You have to have more blood in than blood coming out. Very simple. If you have more blood coming in than coming out, you'll get an erection. So a venous leak means it's coming out too quickly.
So everyone's evaluated for that after surgery in all these situations?
Well, you know how you can tell? You have 2 questions. The number 1 question is the guy will tell you, I'm having trouble maintaining the erection. I can get the erection, I can't maintain it. It's a venous leak. That's what he's telling you. I can get it, but I can't maintain it. It's the number 1 cause of ED in the world. That happens first, venous leak typically.
Interesting. The question over here?
I believe you said earlier that instead of exogenous TRT, you might consider something, I think I've got it right, HCG therapy to stimulate the testicles. For someone with a Gleason 9 and who's already had IMRT and an ADT as well, would the more natural testosterone still pose a risk for progression?
So I don't want to get misconstrued. It doesn't matter if you're taking the natural or the exogenous. Testosterone is testosterone. So I don't want someone to think that, you know what, I have a very aggressive disease. Maybe it's safer to raise my own endogenous. There's no data to support that. I would still have the same cautions.
And then the last one there. You've probably heard every Viagra joke in the book, haven't you?
Probably.
My favorite is Honeymoon Niagara 50th Anniversary Viagra. That's one of my favorites. And then, did you hear about the new side effect with Viagra? If you don't swallow the pill fast enough, you get a stiff neck. So that's all right. This keeps me popular, trust me. All right, sir.
I have heard, and I'm hoping you can confirm or deny, that beer is beneficial in the natural production of
I can
testosterone.
answer that.
Beer?
And if it is Labatt's or Lone Star preferred?
It's Lone Star. It's from Texas. I don't know any data to support that.
How about in terms of alcohol and sexual function or erectile dysfunction? Because we're told that alcohol in moderation is heart healthy, so maybe that helps. But then again, we know it can also suppress testosterone in extremely heavy amounts.
Sure.
So what do you tell patients about alcohol besides the fact that beer is so great?
Well, I mean, alcohol decreases the efficacy of the PDE5 inhibitors, so be careful, right? That's one. So if you're going to drink, it's going to make that pill less effective, right? And obviously, alcohol in moderation may be reasonable, but clearly, obviously, too much alcohol makes it's a risk factor for ED.
Was that the answer? The answer is absolutely it helps. Yeah, no, that's true.
I haven't seen any data on that.
But I will tell you, this goes personal in this sense. We talk about sugar, we talk about all these things. Alcohol is 7 calories per gram. It is one of the greatest concentrations of calories ever invented in human history. So if you're gaining weight because of it, which a large number of Americans are gaining weight because of alcohol consumption, it's killing your testosterone.
That's
correct?
That's true. You're rheumatizing.
So I think we have to keep you moving, and that's a tough spot. 2 hours, first timer at PCRI.